John Bennett, home of Neurosurgical TV. We have the pleasure of broadcasting as we have for the past 11 weeks. This is number 11 in the series of Neuroendoscopy by Y.R. Yadav, president of the Neurological Society of India. And now he's on number 11. And to moderate the proceedings is Jitin Bajaj. He's a neurosurgeon from Jabalpur. Welcome, Dr. Bajaj.
Thank you. Thank you, Professor John Bennett. Greetings, respected seniors, colleagues from Jabalpur, India. Thank you for joining today. Today is the 11th webinar of Professor Y.R. Yadav Neuroendoscopic Series. And today's topic is endoscopic posterior approach for multi-level cervical myelopathy. Professor Y.R. Yadav doesn't need any introduction. He is the current president of NSI, former head neurosurgery and director of Super Specialty Hospital, Medical College, Jabalpur. He has published more than 350 articles and has conducted several operative and cadaveric workshops and delivered multiple lectures. His book on neuroendoscopy is one of the highly acclaimed and bestsellers. Thank you, sir, for coming. Today we have with us an esteemed panel group. Professor Suresh Sankla, sir, is president of Neuroendoscopic Society of India. He is the head of department neurosurgery at Global Hospitals, Mumbai. Professor Kodiswaran M is the head of department neurosurgery at Philpott Medical College, Chennai. And Professor Rashim Kataria, sir, is senior professor neurosurgery at SMS Medical College, Jaipur, India. All of them are expert neuroendoscopic surgeons and published heavily on this topic. Thank you very much for agreeing and coming. Last but not least, I thank Dr. John Bennett for organizing this series. Without much ado, I request Yadav sir to start his talk. Thank you, sir.
Thank you, Jitin, and thanks to all the panelists. And I am grateful to John Bennett, sir, for the opportunity he has given to me. And I am also thankful to the viewers without which you get encouragement because more and more people watch you. So thank you all. Today I'll be talking, I think I need to share first. So I'll be talking on endoscopic management of so can you see my slide now?
Yeah, perfect.
Yes, sir.
Yeah, endoscopic posterior approach for multi-level cervical spondylotic myelopathy, which is quite common. The endoscopic approach for cervical degenerative, this is cervical spondylosis is a degenerative process, and this involves not only disc, but it also involves oncovertebral joint, it involves facet joint. So there are degenerative changes, and there's a hypertrophy, and also there is hypertrophy of the ligamentum flavum, and all these things lead to compression on the root or on the cord. So initially, majority of them obviously can be managed conservatively, and natural history is unpredictable of cervical spondylosis. Sometimes it progresses, then it remains stationary for quite long period. But majority of them, if these degenerative changes are significant, they require some sort of surgical treatment. And so when you talk about the surgery, I'll also discuss the indications. Before that, if surgery is required, then whether you should take anterior approach or posterior approach, this remains a question, because as you know, I have discussed that the pathology is at the disc, which is anterior to the cord or the root, and the pathology is also at the facet joints. So these are the structures which are involved. So the disc is lying anteriorly, the oncovertebral joint can produce changes more anteriorly, facet joint changes produce compression from posterior side. The ligamentum flavum also, the compression is from posterior. So these two structures cause compression from anterior and these two from posterior side mainly. So depending upon which component is predominant, so if you have compression primarily from anterior side and it is of 1 or 2 level, then anterior approach is indicated. But if it extends 3 or more than 3, then and if it involves the vertebral body, so the fusion of 3 level and more are associated with lot of side effects and morbidity, and therefore there is controversy whether you should go in anteriorly or posteriorly. So by and large, most people believe that if the pathology is more than 3 segments, even if the compression is coming from anterior side, provided there is a normal lordosis and provided the compression there is K-line positive, that means the compressive element does not extend beyond posteriorly beyond the K-line. So this is the K-line, that midpoint of lower end of C2 vertebral body to the spinolaminar junction to C7, upper level of C7. So from middle of these canal, if you take a line and if the compression is lying anteriorly, this is known as K-line positive. So that means if the compression is about less than 50% of the canal diameter, then you can go from the posterior approach, because although the compression is from anterior side, but you go for indirect decompression from the posterior side. So normal or even kyphotic deformity, you can go for anterior approach, but if there is a kyphotic deformity, then don't do the posterior approach, because the except for the ligamentum flavum hypertrophy or facet joint compression, the rest of the pathologies are lying anteriorly, and it is an indirect decompression. So if there is a kyphotic deformity, the cord does not expand posteriorly. So what does it mean? The indirect decompression means when you do laminectomy or decompression from posterior side, and there is a compression on the cord, so cord shifts posteriorly. So it is an indirect decompression. So and if there is a kyphosis or loss of lordosis, in that case, the cord does not, cord is not allowed to expand posteriorly. So therefore, your decompression will not work. So, it is not indicated anterior approach when there is a congenital canal stenosis, or if the OPLL which is there is intradural. And how do you find out whether the OPLL is intradural? If you have hypodensity in between, that is double ring sign, which I'll show the photographs later on, or OPL is densely adherent to the dura. So in these cases, the chances of CSF leak and the dural injury are more. So it is better to go for indirect decompression from posterior side, although the majority of the the disease process is anterior. So the indication of posterior approach, which we'll be discussing today, are when the compression is primarily from posterior side. That means when there is a ligamentum flavum hypertrophy or facet joint hypertrophy, which is causing compression on the cord or the root from posterior side. So it is best to go from posterior side. If the compression is from anterior side, go from anterior side. If it is from posterior side, go from the posterior side. The only exception is when you have more than 2 level, 3 or more level compression, although even if it is from the anterior side, and if it extends more than 3 or more than 3 level, the results of surgery when you go from anterior approach, especially in OPLL, are poor as compared to, are either same or poor when you do it from posterior side. So even if the compression is there from anterior side of 3 or more than 3 level with normal lordosis, because that will allow the cord to expand posteriorly, or K line is positive. That means the compression does not extend beyond 50% of the canal by and large, although you should you should make this line and find out if the compression is going posterior to the K line, then I think there is a need for going from anterior side or anterior and posterior side both. Because limited decompression up to 2 level, 3 level, or multiple level disc also can be done. But I told you that the morbidity of extensive anterior decompression is higher. The pseudoarthrosis and other complications related to failure for graft take-up are very high. Anterior and posterior compression. So if you have both anterior and posterior compression, and there is a lordosis, or if the the compression from anterior side does not extend beyond K line, then you can take the posterior approach, and it can be done when there is a congenital canal stenosis. The compression, there can be situations, there are always possibility that you are in doubt. There is anterior compression, posterior compression. It is at 2 level, less than 3 level. So you are confused whether the main compression is from anterior side or posterior side. So in such cases, what you should do, that you should go for dynamic MRI. So if the compression on the cord increases on flexion, MRI taken on flexion, in those cases you should go from anterior side. But if the compression increases on MRI in extension, that means the posterior element compressions are more prominent compared to anterior. So compression increases on extension in dynamic MRI is an indication for posterior approach. And although the disc is lying anterior to the cord, but if there is a soft disc which is lateral, near the lateral margin of the thecal sac, that also can be addressed by posterior approach. And if there is OPLL, although the lesion is lying anteriorly, but the OPLL is intradural, which is shown by double ring sign. And if you have single lamina, which I'll discuss. So if you take a axial CT scan, and in one axial cut, you see 2 laminas posteriorly. So if you see 2 laminas in a single cut, that shows that there has been a hyperlordosis, and these patients are a good candidate for posterior approach. So the indication of posterior approach are, or for surgery for that matter, when there is a persistent radiculopathy, which is unresponsive to the conservative treatment, that is, you tried all methods of medicines and other therapy. And if there is a myelopathy, then obviously it is absolute indication for surgery. And if you have both myelo and radiculopathy, so myeloradiculopathy, and if your patient has a double ring sign, so there is one hyperostotic bone, and there is another bone, and there is a soft tissue in between. So hypodensity in between, that means it is a part of the dura which is not calcified. So this dura, which is posterior to this hypodensity, that is of the dura, is also calcified. So it is a calcified or ossified intradural OPLL. So that means if you try to do surgery in these cases, you will tear the dura and there will be CSF leak. So these cases, even if the the compression has extended more than 50% of the canal diameter, it is not safer to take anterior approach, although the lesion is from anterior side. And if I told you that if you find a single lamina, so this is the example in a single axial cut, you see one lamina and you see another lamina. So that shows that there has been hyperlordosis. So if there is a hyperlordosis associated, the compressions are from posterior side, and it is better to take the posterior approaches compared to anterior approach. So the indications for posterior approach are multi-level, that is more than 2 level anterior compression, including OPLL, but there should be a lordosis. Why lordosis? I told you that since the majority of the compression is normally from anterior side, and it is an indirect decompression except when there is an isolated ligamentum flavum hypertrophy or facet joint hypertrophy out of proportion to the disc involvement or the OPLL or the osteophyte which is coming from anterior side. So in such case, you take anterior approach, posterior approach, and anterior posterior compression with lordosis or congenital canal stenosis or posterior compression secondary to facet hypertrophy or ligamentum flavum, because these compressions are from posterior side. And when you have doubt about whether it is the predominant anterior compression or posterior compression, when the lesion extends 2 level or less, in that case, the dynamic MRI in extension, if the compression is more, then you should go from the posterior approach and the lateral soft disc, which I have discussed. So only those lateral soft discs which are within 5 millimeters of the lateral margin of the thecal sac, and that disc should be soft. If it is a osteophyte coming from anterior side, then that is not a good case. So only a soft disc and it is lying lateral near the lateral margin thecal sac, that is the indication that from posterior side without disturbing the disc, disc preserving surgery can be done. The contraindications are when there is a significant anti-compression, in most cases when canal compromise is more than 50% from anterior side, then either you take anterior approach, or even if the compression is extending more level, then I always tell my patient that you might require anterior decompression of 1-2 level in the lateral part, because extensive anterior decompression is associated with more morbidity. When there is a kyphotic deformity, I told you why, because in most cases the posterior approach in spondylotic myelopathy, it is an indirect decompression. So the cord needs some space to expand posteriorly. And when there is a kyphosis, it does not expand posteriorly, and therefore there is no good, rather it may do some harm. Unstable spine, the trauma, the infected disc disease. The advantage of endoscopic approach over the open approaches are that there is a preservation of motion segment and the disc, because you don't go through the disc, so there is no damage to the disc. Therefore, the motion segment is preserved. The prevention of the adjacent segment degeneration, because the disc is preserved, therefore the adjacent segment degeneration does not occur. There is a prevention of post-operative kyphosis because when you go for posterior approach in a long term, there may be post-operative kyphosis. And this is because of the destruction of posterior supporting structures. So those are the ligament, the supraspinous ligament, interspinous ligament, and the muscles attached to the spinous process or the various part of the spine. So these structures, majority of them are well preserved, and therefore the chances of developing post-operative kyphosis as we come across in open laminectomy is almost zero. So it preserves the ligaments and it preserves the muscles and the facet joint on opposite side and the lamina of the opposite side also. What is very important for a clinician to find out how many levels are involved? There should be a good clinical and radiological correlation. Usually when you get a radiology, because this is a degenerative process which extends many levels. So there may be 4, 5, 6 level of involvement, but the causative, when the patient symptoms may be related to 2 level or 3 level or 4 level. So there should be good clinical and radiological correlation because the radiology may look very extensive, but you require possibly less number of level to be decompressed. So how do you decide how many level to be decompressed? So for that, it is better to have the compression ratio, that is the sagittal diameter divided by the transverse diameter. So that means the AP diameter and the transverse diameter. The sagittal diameter divided by transverse diameter, and if it is 0.4 or less, that means that level should be decompressed. Or if the transverse diameter, that is AP diameter, sagittal and transverse, AP into transverse diameter, if it is 40 millimeter square or less, so if the diameter is 40 millimeter square or less, that also level should be decompressed. So 0.4 or less AP diameter or 40 millimeter square or less, or if there are cord changes associated, in that case surgery should be done. The posterior decompression being partly indirect process, except that if there is a facet hypertrophy or ligamentum flavum hypertrophy, which is usually associated because these are generalized degenerative process, involves all 4 structures. I have discussed the disc, the uncovertible joint, the osteophyte coming from there, and sometimes the OPLL also. So all these things are coming from anterior side, the ligamentum flavum, and the facet hypertrophy comes from anterior side compression. So because it is an indirect decompression and the cord has to move posteriorly, therefore it is always advisable if the compression extends at 3 level, supposing C4, 5, 6, then you have to remove 1 lamina above, that means C3. There should be gradual shifting of the cord posteriorly. So if there is a sudden shifting of the cord posteriorly, there may be kinking and the patient may deteriorate. So if there are exactly 3 level of compression, then you require decompression of 5 level, 1 level above and 1 level below, because it is an indirect decompression and the cord requires some space to shift posteriorly. So that one should look, take into account. Regarding the surgical procedure, general anesthesia is used. Patient in prone position, flex the neck so that the occiput does not obstruct proper docking of the tubular retractor. Otherwise, every time you want to angulate it caudally, the tubular retractor strikes on the occiput and you are not able to work. So make sure that neither occiput nor the shoulder, I mean the region of area in the shoulder region or in between these two shoulders do not come in your way while you are angulating your tubular retractor. So elevate, flex the neck sufficiently and elevate the neck and occiput so that they do not come in your way while you are operating. So localize the level as always in endoscopic surgery because you have to be dot at the level where you want to operate. But there are some problems. There are obese patient in which the shoulder comes in your way and you are not able to localize the localizer at C6 or C7 level. So in that case, what you can do is that you start from the higher level and keep marking and keep writing that this is C3, C4, and then you can see C5 also. And then you can extrapolate the same distance inferiorly. If try and pull the shoulder down, if you can see the level, then it is fine. But if you can't see this, then you start from above and you can extrapolate that possibly that will be the site. So this is the localization, and there is single level versus single versus double incision. So you can take either a single incision, but if there are more than 3 levels involved, then you might have to take 2 incision or take a large single incision. So these are the 2 possibilities. Previously, I was using 2 incision, but now I favor little larger single incision because working in a single incision is better and retracting the muscle after finishing at 1 level and then going on to the second level becomes quite difficult. Surgeon stands on one side, on the side of the approach, and it is usually on the left side for a right-handed person because you have to decompress bilaterally. Unless there is asymmetrical compression, then you come from the side which has larger compression. Otherwise, for a right-handed person, because the patient is in prone, so I take usually the left side approach. It is easy for surgeon. The monitors are placed on the opposite side. Skin incision is approximately 25 to 30 millimeter in size at the level of pathology, and it is about 1 to 2 centimeter away from the spinous process, away from the midline. The small incision is preferred because there is less bleeding. Some of my residents used to give larger incision, so that is a disadvantage. If you give large incision, the tubular retractor causes tamponade effect on the surrounding muscles. So a large incision will not allow that tamponade effect, and there may be some oozing from the surrounding muscle. So it is not an advantage. And if 2 incisions are required, the distance from the midline should be different. Otherwise, I mean, it comes near the lower end of the upper incision. So If the upper incision is 1 centimeter away from the midline, the lower incision should be 2 centimeter away from the midline. So these are not in the same distance from midline. Soft tissue should be retracted by cranial caudal lateral displacement by the gauze pieces. And of late, I have started using retraction sutures on the muscle. So what I do is that I apply a suture on the deeper part of these paraspinal muscles, and then I retract them so that they don't protrude inside the tubular retractor when you are doing surgery. The soft tissue lying on the lamina facet joint and in between the laminas are removed as always in the lumbar spine. So anything which is there where you want to remove that compression, that means on the lamina, near the facet joint, and on other lamina. So all soft tissue you remove, and you should go for perfect hemostasis. If there's a lot of bleeding and you open, you drill the bone, remove the lamina, and a lot of oozing is there, it is difficult to work. So maintain absolute hemostasis, and then only you remove the lamina. You can use Destendo set, which I was using before, but the problem with Destendo is that one of your hand is occupied in holding the set. So now I prefer any tubular retractor which allows me to station that tubular retractor and then work with both the hands. So I now use EasyGo system, but there are other systems also very, very good. So any tubular retractor which holds telescope at the periphery is good enough. So that should be used, and initially use fluoroscopy to find to take where the incision should be given, and then when you have exposed the lamina, then also you should take the fluoroscopic UC arm to find out where you are. And I make a hole, drill it partially in the lamina, and then find out where I am. So that will be my, the orientation, and then I go cranial caudal depending upon how many laminas are involved, and then remove those hemilamina, and obviously opposite. So point about, I have come across situations when I did not do sufficient flexion. So if the patient has a lordotic spine, cervical spine, then one spine is above, the other is also above. The middle spina is way deep in the field. So there will be difficulty in doing surgery. So it is better that you do little bit of flexion at the cervical spine so that all the laminas are at the same level. So you can dock your tubular retractor very well and take out all three laminas using this tubular retractor in one position with little bit of cranial caudal angulation and movement. This is exposure of the lamina. Medial, lateral, the lamina is exposed cranially, cranial caudal, you should be knowing, and then you drill the lamina using high-speed drill until you find a egg cell, only a small little lamina adjacent to cord. So drilling should be done, and then you leave little bit of posterior lamina and remove that lamina with fine Carrison punch. So I use only 1 millimeter Carrison punch. If there is too much of compression and if you use thick Carrison punch, it may cause irreversible damage. So go for egg cell drilling, use fine Carrison punch, especially in poor neurological status, or even use micro forceps to remove that axial part of the lamina which is there. Regarding removal of the other side of the lamina, so remove, this is the example, remove the ipsilateral lamina, part of the facet joint, and then you angulate your tubular retractor in the opposite side. So drill the base of the spinous process here, and then you undercut the inner side of the opposite lamina. So undercut this. So I have told you the trick of how to undercut this. If you drill the lower part of this lamina, then it might also injure this is the lamina, this is the ligamentum flavum. So if I try to take out this part, inner portion of the lamina, this may also injure the ligamentum flavum and the dura. So what I do is I leave little bit of very thin piece of inner lamina intact. I drill this portion which is near the inner portion of the lamina. So I make a hole here as a gutter, and then with Carrison punch or dissector, I take out this axial portion of the lamina with micro dissector, and then further on drilling here, leaving small bit of bone, axial bone intact, and the drilling is always parallel to the cord. Never go towards the cord, otherwise it can injure. So this is the trick. So you can remove the opposite side lamina and even undercut the opposite facet joint. So this also can be done very well. I'll show it in the surgery video, which I'll be showing in this webinar. The other small trick is leave a small portion of, so this is the lamina. You want to remove this lamina and then undercut the opposite side lamina. So I leave behind little bit of this lamina near the facet joint. Why? Because when I tilt it on the opposite side, my tubular retractor will be like this. So if I don't leave this piece, there may be a chance that the tubular retractor, if you use a smaller size, 15 millimeter or even less, 10 millimeter, then it may go inside and cause damage to the cord. So this bone, because this bone is hardly 10 millimeter. So if you keep little bit of the lateral part of the lamina intact in the beginning, which you should remove in the last, then even angulating it and doing the undercutting, you will be very comfortable that it will not sink inside the cord, especially when you use the small tubular retractor. So this is the final diagrammatic representation, that you remove ipsilateral lamina, the desired level, whether it is 3 level, 4 level, 5 level, or 6. I have done up to 6 level, and then you undercut the spinous process towards the cord and undercut the opposite lamina. So what you have done is 1.5. So ipsilateral whole lamina has been removed. The inner half of the opposite side lamina also has been removed. The base of the spinous process towards the cord has also been removed. So you create a nice decompression of the cord, and after surgery, you see, this is the cord, the ipsilateral side and the opposite side. So whole thecal sac is decompressed very well, and you find good dural pulsations. So well decompressed thecal sac is the end point. So ipsilateral and opposite side. So one important point, as in the lumbar spine, is that when you are doing bony work, then do not remove ligamentum flavum. that ligamentum flavum protects the cord from injury. So keep ligamentum flavum until you do all bony drilling. So initial bony drilling should be there. Don't remove the ligamentum flavum. But once you have removed all the bone, then you remove the ligamentum flavum. And after that, you will find that there will be good dural pulsation and nice decompression can be seen. So that is the end point of your surgery. If there is a lateral disc, I have been discussing that if there is a central disc, you cannot go from posterior side. But if there is a soft disc, which is within 5 millimeter of the lateral margin of the thecal side. So within 5 millimeter, because a little bit of retraction of the cord can be done, but you cannot remove the central disc. If the disc is there centrally lying here, then you cannot come from posterior approach and take it out. So soft disc, which is within 5 millimeter of the lateral margin of the thecal sac, can also be removed from posterior approach. So advantage of the posterior approach is that you don't disturb the disc at all. So all normal disc. So this is a disc preserving surgery also. You are coming from posterior side, only you are removing the fragment which is causing compression on the root, causing radiculopathy. So if there's a myelopathy, then you don't go from posterior side, only radiculopathy. The fragment is soft and lying laterally, can also be approached either from anterior side and from the posterior side using endoscopic approach. And now there is another condition which has been described, but unfortunately it has not been used so popularly by many people. But one of the author has and I am impressed. This fellow has suggested that in cervical spine, this is the kind of arrangement. This is the spinous process. So caudally, the B distance near the spinous process, the canal diameter is sufficient. B is always much larger than the distance at the cranial portion of the lamina. So the cranial part of the lamina dips more towards the cord, and this is the example. At the base, there is more canal diameter, but cranially there is less canal diameter. So if you only remove the cranial part of the lamina, leaving behind the caudal part of the lamina, and remove the ligamentum flavum, so in that case, it has been suggested that you can do good decompression. So only a part of the lamina you remove, thereby you improve the alignment, and the chances of kyphosis and other deformity in the long-term follow-up will be less. So this is known as archocrestectomy. So removal of only the upper part of the lamina, leaving behind the inferior part of the lamina intact is one of the options. And this is what the surgeon has explained. This was done by Acker et al. And in 2012, they have said that leave the caudal portion. So remove cranial half, which is more causing compression, and also remove the ligamentum flavum. When for adjacent level, the system can be inclined cranially, caudally. Up to 2-level laminectomy, you can do it with one single incision. But if there are 6-level or 5-level or 4-level, then you require 2 incision or a larger incision. So initially I was using 2 incision, but now I use single incision because in finding a lamina in this another incision, because we don't have two tubular retractor. It takes about 15-20 minutes again. So it's better to have a single incision. This is a short video of a patient, 58 years, gradually progressing quadriparesis, C3 to C6 level compression, preoperative MRI, significant patient positioning, and the level is skin incision. This was 5 level decompression. So obviously incision was little larger. So axial drilling of the lamina. This is the right side, the ipsilateral side towards the facet joint, the cranial side. The lamina is being removed after axial drilling, and now I am going on the opposite side. I am drilling the base of the spinous process, and then this is the lamina of the opposite side, which is being drilled now. You see that gutter-like drilling is done, leaving behind little bit of lamina inferiorly, as I have discussed, and then that inferior lamina which was left in the drilling. So this was the gutter created by drilling, and small little inner portion which was there is being removed using Carrison punch. So this is opposite side, this is ipsilateral side, and after the bony work has been done, the ligamentum flavum of the ipsilateral side and the opposite side is removed. And once you remove the ligamentum flavum, then you see cord very well. So opposite side ligamentum flavum right down to behind the facet joint on opposite side is removed. The ipsilateral ligamentum flavum is removed. And then I told you that some portion of the bone lamina, lateral lamina is left, which will prevent your tube to sink. So that bone also in the end should be removed, and you don't allow any spicule. So this is after the decompression. You can see a nice decompressed cord on opposite side and ipsilateral side. So hemilaminectomy of this side has been done, and undercutting of the opposite side lamina has been performed. And this is the decompressed. Well, you can realize the pulsations, and then in the gutter you place the abgel so that there is absolute hemostasis there. If there is a post-operative some hematoma, then it delays recovery of the patient. So absolute hemostasis should be done. And this you can realize that ipsilateral lamina on the left side and undercutting of the lamina, and these from C3 to C6, C3 to C6, 4-level decompression was done. Regarding the results, we had so far we have operated 156 patients. Age range from 45 to 75, up to 6-level decompression has been done. The post-operative grading improved in all patients. The average preoperative neuric grading was 2.6. It varied from 0 to 4, but average post-operative neuric grading improved, and all patients improved in their neuric grading from I think 1 to 2. So they improved, all of them, either 3 neuric grading or 2 or 1, but there were 6 patients in which there was neuric grading 0. So the zero cannot improve. So they had root pain, only root pain, there was no myelopathy. So these patients also improved, although they remain in zero grading, but their root pain improved. So mean preoperative and postoperative Cobb angle at decompressed level was also same. So there was no kyphosis or any unstable spine in the follow-up. The mean operating time for single level is 40 to 50 minutes. But if there are obviously 6 levels, then it takes more time. The mean hospital stay is also less. The mean loss of blood is very small, average 30 ml. The follow-up range from 6 months to as high as 112 months. So long, we had long follow-up, average of about 5 years. The complications, minor dural tear in 2 cases, no CSF leak, because we go for delayed suture removal, and you can put in lumbar drain, and there are methods of treating the dural tear. The minor bleeding from the muscle or epidural vessels in 12 patients, which could be controlled with bipolar and other methods, bone wax, if it is coming from bone. There were temporary C5 root injury. So C5 palsy was there, which is quite common when you do open surgery because of stretch on that root, which improved gradually in the follow-up. So this is one case of preoperative MRI, C3-4 compression to C6-7 compression, and post-operative decompression. You can see that there is an undercutting of the lamina on the opposite side, and hemilaminectomy has been done. So well decompressed thecal sac, 3D reconstruction showing ipsilateral hemilaminectomy, and some base of the spinous process has been drilled, and also opposite side undercutting of the lamina. Another case, and here you see that the canal diameter has improved after surgery. So to conclude, the posterior approach is indicated when compression is primarily from posterior side, or anterior compression of 3 level or more with normal lordosis or K-line positive case, or anterior posterior compression with lordosis, or compression increases on extension, the presence of congenital canal stenosis, and when there's a soft lateral disc. So posterior endoscopic decompression surgery for cervical myelopathy in the spondylotic cases is effective and safe alternative, but there's a little bit of learning curve which one should overcome. We have these 2 training programs of 1 year neuroendoscopic course, and also a week endoscopic training program every 6 monthly. Thank you very much. Thanks.
Thank you very much, sir, for such an elaborative talk covering every aspect. Before taking up the questions, I will request panelists to give their comments and as well as ask questions. I will request Professor Sakla, sir, to ask us.
Thank you, Professor Yadav, for such an excellent discussion and demonstration of the technique. I think for the young neurosurgeons, I think it is a very simplified way of showing the procedure, and this technique is very, very simple. But there are certain things like doing it at the multiple levels, and doing across the midline and going to the other side and doing decompression. I guess that comes with time, and you need a good learning curve, and with time you can achieve that expertise. But for the beginners, I think you must start with a single level surgery and then decompression as you do in the lumbar region, similar way. And check the position of the tube. That is the most important thing. Dr. Yadav also emphasized it so well. And good decompression can be achieved without any problem. So let us have the words and comments from the other panelists also, and then we'll go on with the discussion.
Thank you, sir.
Okay, Rashim.
Rashim, sir, please.
Yeah. Thank you so much, sir, for a very comprehensive posterior cervical endoscopic laminectomy. So my only thing is, like, how are you going to deal with the CSF leaks which can happen during this procedure, endoscopic?
Yes. So if there is a small leak, it doesn't matter. You just can put in fat there, or you just put dura patch and tissue glue, and you can keep lumbar drain for some time. If there is a leak, most of the time small leak it doesn't cause any problem, because the reason is there is no dead space. So if there is no dead space and if you come across a leak, then you should go for multiple layer good closure of the repair in multiple layer, and apply skin stitch. Otherwise, we normally do not. We go for subcuticular stitches. But when there's a leak, I tell that please go for a skin stitch and delayed skin stitch removal. And if there's any leak, then we put in lumbar drain and it works. There is no problem. But if there is a large leak, then you have to either use those facial lata or a fat, put it inside and then put tissue glue. That works very well. If there is a bigger tear, which fortunately we never had, because we gradually went, we did cervical spine later on in our learning curve, after having sufficient experience of other endoscopic surgery. But I can repair dura using endoscope. But most of the time the tear occurs, it is very zigzag and difficult to repair. So just put in fat or dura patch or the facial lata and the glue and good dural closure along with the lumbar drain. It works in all cases. Yeah.
Thank you, sir.
Dr. Yadav, venous
Sir.
bleeding, epidural venous bleeding can be a problem at times. I know you have discussed about it during your presentation when you were talking about it.
Sir.
But
Sir.
you know, can you give some more
Yes,
tips and some
Yes, sir.
way of controlling it
Sir,
for our younger audience?
because of the time, I thought that every time I am exceeding time. So I did not, very important point, how to control venous bleeding. It is very simple. Just put in either Surgicel or Abgel in between the dura and the bone. Just put in, it comes from the lateral side near the facet joint or the lateral side of the lamina. So keep that Surgicel or gel foam. Usually what we do is that we leave Surgicel or gel foam there, and then we try to suck, then it comes in your suction. So hold that Surgicel or Abgel for some time and keep that in between the dura and the bone. So it's a venous bleeding, it stops. And another thing is that I try to avoid the bleeding. So I first take out the bone, and when I see carefully, I look at the vessel. If I find some vessel, I first coagulate it, and then take out the ligamental flower.
Right.
But
Thank you.
just putting in a surgicel or abgel between bone and the dura, the bleeding stops at an elevation, the warm saline irrigation, and hold on for some time, just keep petty for some time. It stops, sir.
Thank you.
Sir.
Thank you, sir.
Yadav, sir. Yes, sir. Yadav, sir, that's a wonderful demonstration of this kind of procedure. It's totally new to us. My doubt, for example, if you are doing 6-level decompression, the incision will be almost same to the open procedure. So what is the advantage? Means, for example, our curiosity is how we are doing that muscle work.
Yeah. I mean, obviously the incision is larger, but it is not as large as open surgery. Obviously, it will be larger, much larger, because you don't require any retractor or anything. So it is much smaller, but still, if there are 6-level, you have to have a little larger incision, and the time taken for going there is less because the incision is large, so you can dissect your muscles and everything from the lamina quite quickly. But I agree that the incision, obviously for 6-level, is larger. It may be about maybe 6, 7, 8 centimeters. That's all. So you need not to go right up to the lowermost lamina. You can incline it little bit. But I agree that the skin incision and everything which is planned, the initial work is done by my colleague. So they err on little larger size. So they give little larger incision. But this can be done with the smaller incision also.
Another issue is the muscle bleeding, no, sir? While you're going inside, the bleeding from paraspinal muscles.
Yes. So you do the same thing. The larger the incision, there is hardly any problem. But otherwise, what you remain subperiosteal, and if there's any bleeding, you use bipolar forceps. You use right angle retractor, the smaller size right angle retractor to retract the muscle. Okay, and then work there. The only problem which I used to find when working on the opposite side, when you angulate your tubular retractor on opposite side, the soft tissue, and then you again bring it vertical, then the soft tissue from ipsilateral side, the muscle used to come inside the tubular retractor, and then you waste about 5-10 minutes. So what after knowing this, after some time, we started applying the stitch on the deeper part of the muscle, one stay suture, and then retract it. So that's a good method. But obviously, the retraction of the muscle and everything much less compared to the open surgery. Yes.
Otherwise, you can use that
it is only on one side. So opposite side muscles, paraspinal muscles, open lamina, these are all preserved. Yeah. Yes. What was your query?
So actually, another idea, we can use adrenaline soaked gauzes with saline. We can, once you open inside and pack for 2-3 minutes. So it will reduce the bleeding.
Okay.
After dissection of paraspinal muscles from the lamina, we can tie a gauze soaked with adrenaline saline and put it inside for 2-3 minutes, then take it out, then go for procedure.
Okay.
So that will reduce the bleeding.
Yes, good idea. But I think even under vision, it can be done.
Yes,
But a good idea. It's a good suggestion.
Next thing, yes, sir. The ECG also, you will move level by level. Correct, sir?
Easy go, yeah. Normally at one level, because this is if there is a multi-level problem, I use the largest tubular retractor. So 2 centimeter diameter, usually stationing one tubular retractor, you can take out 2 lamina very well without moving it. Yeah, so one
Yes,
by
sir.
one, obviously, one by one.
Anyway, actually, even though
And-
it's looking very
and-
simple from
Initially, what I was doing, I was initially removing all lamina from C3 to C6 on one side and then going contralateral side. But now I do full work. I mean, I remove ipsilateral lamina, I undercut the spinous process, and I undercut the lamina of the opposite side. So one level complete work and then next level complete work, and like that. And when you have a larger incision, because there is a sufficient space, so I use my finger, cranial or caudal, to retract the muscle when I move my tubular retractor. So my tubular retractor is here. If I want to move it caudally, then I put my finger caudally, retract the muscle, and then I prevent this muscle coming in my way and going inside the tubular retractor. So because there is more space, so you can use the finger as a retractor when you move from cranial to caudal or from caudal to cranial, whatever way you want.
yes, sir. Anyway, it looks simple from your side, but it needs long-term expertise. Otherwise, it is not an easy procedure. That is my
Yes, I
opinion.
agree. I agree, yes. So we started it after doing, I think, a lot of work. I did first lumbar spine and then pituitary and other things. And after 2, 3, 4 years of experience in endoscopic surgery, then we moved to posterior cervical approach. So I did anterior cervical first. Anterior cervical is easy, 1 or 2 level. Posterior cervical, you need little more experience to it. So there should be graded. I mean, you start with simple case and then you take difficult cases.
Yes, sir. Thank you.
Thank you, sir. So we have with us Dr. Harshad Parekh, sir. He has asked multiple questions. If he's here, he can ask directly.
Okay, so one is
Yes, he's here.
do you remove the spinous process along with the lamina? No, the spinous process is not removed, only the base of the spinous process, because without which you cannot go on to the opposite side. So base undercutting of the base of the spinous process is done. The no spinous, the full spinous process is not removed. And is there any danger of using flexion of the neck? Yes, but that should be guarded. I mean, it is not too much flexion, but just making sure that your all lamina, the tubular retractor docks well, and it is not displaced because of the extension. So you don't keep it lordotic, just keep it flat. So that you require, yes. What is your view on lateral? Just facetal screw fixation? I am aware Professor Goel says that these are all protective phenomenon, and if you just stabilize them, it disappears. And he has shown his experience, which I completely agree. But I have no experience, sir. If there is those things are there, I remove it, although it may not be scientific. But he believes that these are all compensatory phenomenon, and if you stabilize them, they disappear. And he has shown in his presentation that in post-operative period, they decrease. I am aware of it, sir. Anything else? Please elaborate on the incidence of C5 radiculopathy. It is basically, some people think that it is vascular, some people think it is just a posterior displacement of the root, which may cause a temporary C5 radiculopathy. In endoscopy, fortunately, in my experience, it has always been temporary, and with some time, in few weeks to 2-3 months, there is a complete recovery. When is fixation required in endoscopic spine? If there is unstable spine, that is contraindication. I don't do simple decompression. If there is unstable spine, that means flexion extension X-ray shows some movement. In that case, obviously you require some fixation also along with decompression.
Hey, Jitendra, you want to moderate and pick the next question, please? We don't
Yeah,
want to
I
make Dr. Yadav work too hard.
Sorry, sir, sorry. So I think he has answered already all questions. And,
Can I ask
Oh,
one?
okay, Dr. Parekh has a few questions, I think.
Who has the question?
Go ahead, Arshad.
Harshad Parekh. I think
Yeah.
we have-
Ed.
Yeah. He answered all questions. Yeah.
Oh, okay.
Yeah. A very nice presentation, Dr. Yadav, as always. And we learn a lot from your talks and your techniques. Wonderfully shown. And yes, it is very interesting. Only my worry was the flexion of the neck, because we have been taught all these years never flex the neck when you are doing a cervical posterior approach, especially for the degenerative spine. Because if there is a compression from anterior, you can compress on the cord by flexion. That's why I asked that question.
Yes,
Thank
you are
you.
right, sir. Absolutely right. You are right. So guarded flexion, otherwise you cannot dock this. And the indication for posterior approach is when the compression, main compression is from the side, plus always guarded flexion, not, extreme flexion is not there, just to make things flat, the spinous process. You don't require more than that. There is no need for opening of the lamina. So you don't flex it to open the lamina, just to allow your tubular retractor to sit comfortably on the lamina. That is what is required, sir.
And removal of a spinous process. I thought you removed the spinous process in one picture. You have shown complete decompression of the cord on
No,
both
sir.
sides.
No, sir.
No.
It might have been seen in between CT scan, but spinous process removal is not required, sir. Unilateral decompression, unilateral approach, bilateral decompression, sparing the spinous process, except the base of the spinous process and the opposite under surface of the lamina.
Yeah.
Sir.
Okay. Thank you.
Sir.
Yeah, Dr. Yadav, you mentioned about removing the soft disc using this approach.
Sir.
Can you just tell us, right from the position of the neck during surgery to where position of the tube, and then how do you do it? Any tricks?
Sir, it is targeted surgery. When you just go at the level, you just localize the disc level. The same prone position, when you go on the lamina, you define the junction between the lamina and the facet joint, and then you drill the superior and inferior part of the superior lamina, part of the inferior lamina, and part of the medial facet joint, and then remove the ligamentum flavum. After that, you will see the root. So you have to retract the root little bit, either depending upon whether it is superior, the disc is superior to that. Most of the time it is superior to this. So you retract little bit of root. That is a disadvantage of posterior approach. In anterior approach, you don't dissect anything, but the little bit of dissection or mobilization of root, but at the advantage of complete preservation of the disc. So you just remove the fragment of the disc, leave everything intact. But this is only for soft tissue. If there is associated osteophyte, then drilling it can cause injury to the dura, to the root, and a lot of mobilization. The root is not advisable, sir. Sir,
Perfect. Thank you.
sir.
Thank you, sir.
We have one more question. Do you want to ask it, Jitin? Go ahead. Go ahead, Jitin.
Yeah, sir. Dr. William is asking, do you have a spinal endoscopy fellowship so he can do it? I think you have answered.
Yeah, I think, but see, what we do is that we do both. I mean, we don't discriminate. So one case in one OT is the spinal case going on, in another cranial case is going on. So this is about 50% cranial, 50% spine, because most neurosurgeon wants cranial also and a spine. So normally we do live surgery about 15 cases in 3 days time from 2 OTs. So that means you normally see 7, 8 spine cases in any given fellowship program. And then you are exposed to training on model and training on animal model and cadaveric dissection in the last 2 days, which you know, Jitin, very well. So it's a good program, but the problem is that if you apply now, you may not get, chance to join endoscopy in 6 months or more than that. Because usually when we advertise it in about 2 or 3 days time, the all seats get filled up. But you can come as an observer and watch surgery whenever you want. It's a government hospital. You can come anytime. There is a fee for fellowship, but if you come as an observer, you don't have to pay anything also. You can just come and stay as long as you want. I think Jitin will help you in getting accommodation in the government guest house, and things are good. Now, Dr. Jitin is in charge of this fellowship program, so you can contact him if you want any assistance, or if you want any assistance from me also. I am ready to help.
Can you put your contact info on the chat, Doc, when you get a chance?
Yes.
Yeah, Jitin, you put the
Okay, to Jitin. I guess he'll write to Jitin, right? Okay.
Thank you. So I'll request anyone else to ask also if he has any question.
Or in case you forget it, it is there on Google. You just type neuroendoscopy Jabalpur, India, and you will find all the information there. And please, Dr. Jitin, I request you please give your contact number in the chat box, or
Yeah, that would be nice. Yeah, William is from Venezuela.
yeah, Jitin.
The gentleman that asked the
Yes,
question.
I have posted the website address. Everything is given on the website. And,
neuroendoscopyjbp.org.
this is our website, yes.
Yeah.
Okay.
With this, I think there is no more questions.
Okay, very good. Thank you very much for moderating, Jitin, and thanks again, Dr. Yadav, another very
Thank you.
interactive session. and thank all the panelists for participating. And so we'll see you for the last one, number 12 in the series of neuroendoscopy, same time, same channel next week.
Thank you.
Thank
Thanks,
you.
everybody.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you all. Thank you. Good night. Good night.
Bye.